look like the border between shift the patient with mechanical ventilator or go back to nasal cannula first. Sorry, high flow, simple mask, nasal cannula discharge. This is very, very important. But the idea here, CPAP means continuous positive airway pressure. Means we are delivering oxygen during inspiration and expiration phase. According to that, we need to be very, very careful for what? When we give too much pressure for those patients, we have a lot of complications. One of the most important, especially for the elderly, is what? Is aspiration pneumonia. Now, the patient, he feels to vomit, and the nurse, no, sir, you are okay, sir. Don't worry, keep it, this is for you. And the patient, I need to vomit, you know? And they keep the patient like that, and the patient, in fact, we have incident again, aspiration, make aspiration pneumonia. This is major problem, especially for the elderly, like me, okay? It's dangerous. Be careful. Other things is very, very important. Some nurses, they are, the patient is put the straw to drink, right? We put straw here. With high flow pressure, lead to what? Lead to aspiration pneumonia. Be careful. It's better sometimes to release, but when you are releasing, be careful. Aerosol, number one. Number two, the patient will be deteriorate. According to that, don't remove the mask at all unless you inform the team leader and the doctors. Because when you remove the CPAP, we are decreasing to the high flow. High flow. At least the patient, he can eat very fast, he can drink, and return back the CPAP. This is very, very important because the patient developing dehydration, developing the patient oliguria. The patient, they are very weak because they are not eating. Because the nurses are very smart, they keep the patient fasting. They don't want to remove the mask. Okay? Next, ensure safety. Why we are making non-invasive ventilation? The non-invasive ventilation, we have something is called CPAP and PIPAP. The CPAP is more advantage than the PIPAP. CPAP. Okay? Number one, increase risk for health worker for aerosol. Next, increase failure rate in non-cardiogenic etiology patients. Some patient with cardiac failure or something is not recommended to use the CPAP. No. Large tidal volume because too much pressure, and facial skin breakdown, injury, and facial injury. Don't wait for more than 1 hour for intubate the patient. Remember, for the CPAP, we have 3 things is important for the setting. You remember the high flow? How much the setting? We have 3 settings. What are they? Setting, high flow. Temperature what? 37. High flow, 60 liter. FiO2, 100. For the CPAP, it's important is the mood. Mood should be spontaneous. As spontaneous means what? Means the patient, he can breathe. Never ever we are putting the CPAP for the patient, he can't breathe. Never. This is high risk, he will die. Now, the mood is spontaneous CPAP. Other things is important. Our target should be between 92 to 100. You need to keep the tidal volume all the time between 6 to 8 liter, 6 to 8 liter per kg. In the mechanical ventilator, the patient has 70 kilogram, multiplied by 6, 420 ml per kg tidal volume. To keep the SpO2 is high. Number 3 is what? PEEP. We are keep the PEEP between 5 to 8. 5 to 8 PEEP. What is the PEEP? Positive inspiratory pressure. The normal PEEP in our body is how much? 5. And we are increasing a little more. What is the most important? To keep the alveoli what? Inflated, not to be shrinking or collapse. This is the most important for the P with the CPAP. CPAP, it's external. We are putting the P with a mechanical ventilator to keep the alveoli is open. This is very, very important. But at the same time, this one lead to what? Lead to a lot of complications. Such as what? Okay, but other things, beep. I think I will give a lot of information today. I don't know what's important. It's important for you or not. I'm not sure. Is it important? Yes. Very important. I try my best to do the picture. Okay. If there is something is important all the time, please think about decreasing what? If the patient developing hypotension, think about this one. B. Why? Because that will lead to increase intrathoracic pressure, lead to decrease venous air, especially right side to the heart, lead to decrease the cardiac output, lead to BP is low. This is called cardiac compromise. Cardiac compromise because of PEEP. PEEP is dangerous. And the PEEP lead to what? Make rupture of the alveoli. Make something is called parotrauma. This is because of the PEEP. But for the vital signs, very obvious. Patient receive PEEP high, patient BP is low. Increase intrathoracic pressure, decrease the venous return to the heart, decrease the cardiac output, decrease the blood pressure. After that, he will get one delivery, Kentucky with sleep. Okay, next. Positive and expiratory pressure. Non-invasive where positive pressure is delivered and maintained through entering a breathing cycle. Okay? CPAP can only deliver for what? Spontaneous only. Next. Never administer or recommended CPAP for the patient who is not breathing. Never. Never. Next. During inspiratory and expiratory cycle, we are given CPAP in the same pressure. It's fine. This is the CPAP to keep the alveoli is open. I don't want to explain for you. This is the mismatch. Little complicated. But the most important to keep the alveoli is open. Okay? Here, it's shrinking because we don't have enough PEEP. All the time, alveoli is shrinking because all the time we are not using the PEEP. Should be keep the inflated the PEEP in a good way. Primary indication for the CPAP, the indicator of the CPAP in general, not COVID patient, the patient with short neck and obese. They have sleep apnea. The breathing is absent up to 10 seconds during night. According to that, we keep the CPAP. Nowadays, they keep the nasal for them, and they keep the mask, and we have sensor. When the patient is not take breath, they give direct CPAP. This is for the patient with obesity, sleep apnea. But the patient with COVID, this is important here to make sure the patient, we are given a lot of things. Now, recognized contraindication, non-invasive generally, not used for the patient with what? Hemodynamic stability. Hemodynamic stability. Say you are ICU, right, in the middle. You are very lucky because left lady in the right and the left, you are in the middle. Yes, sir. You. ICU, right? OT? You are not ICU now? If I mention his OT, you don't know ICU. I remember what you have mentioned here, sir. Yes, sir. A question for you. You are OT. You are working in McDonald's. You need to answer. What do you mean by hemodynamics, sir? unstable hemodynamic. Hemodynamic means the scientific. Hemodynamic means invasive and non-invasive hemodynamic monitoring. Hemodynamic, you remember we have something you need to be stabilize the patient vital signs, the eight vital signs, plus saturation, plus ABGs, plus everything is under hemodynamic. How to monitor? We have invasive, like arterial line, central line, swan catheter, intra-aortic balloon. This is hemodynamic. Invasive. Non-invasive, we have Mariam and Watch. We have non-invasive, we have ECG. We have vital signs. We have cardiac monitoring. All is outside, right? But if the patient hemodynamic is unstable, it's difficult to put the CPAP. Patient will be more deteriorated. Multi-organ failure means moods. Kidney, heart, brain, patient, no way. Abnormal mental status. According to that, we are given what? Brisidex. What else? This is the mood CPAP, PEEP, FiO2, and this is important here. What is the initial monitoring? You are the one you need to do the monitoring for the patient. Number one, be careful, something is called troubleshooting. Why all the time alarm? Because the patient is fighting with the machine. You need to be careful that you are given the Brisidex, the patient stabilize the patient condition. Number two, once the patient is comfortable, check the 8 vital signs. Check the oxygen and the mental status, and trial assessment and reassessment. And we have a trial to success and a trial to failure. What does it mean, trial to success? Okay, let us to go a little back to the ROX. You remember the ROX? And the patient, he has less than 4, the ROX. That ROX, respiratory oxygen and SpO2, less than 4, means that it's failure, this patient failure with high flow. We will start with CPAP. The doctor, he will get ABGs. And the ABGs shows the patient, he has respiratory acidosis. Oxygen is low, pH is low, and bicarbonate is low, and CO2 is high. In this situation, doctor, please prepare for, we can send the patient with the CPAP for 1 hour for a trial. If we are trial within 1 hour, 2 hours, he succeed, this is trial to succeed. Means the patient condition is fine, respiratory increase, ABGs is fine, and hemodynamic is stable. Trial to failure means the patient is not tolerant. Means the patient, he needs what? Mechanical ventilator. Tamam. Okay. CPAP winning. Oh, it's before. Arterial blood gases after 2-3 hours. Patient should be monitored complications such as what? Aspiration and initial ulcer. Check all the time for trial to success the patient. And however, it's improved, show signs, deterioration at the time, the patient needs fail, and the patient needs mechanical ventilator. Weaning, you know what does it mean, weaning? Weaning means remove the patient from the CPAP. When to remove the patient? If the patient, he has the cause why I put the patient. The mechanical ventilator, it's resolved. If it's resolved, I will start to wean. If not, I will send to where? To the mechanical ventilator patient. Number one, the respiratory rate between 12 to 20 or 20, 22, it's acceptable, not more. Peripheral oxygen, again, this is not, where's the guy here? Your good name, sir? Name only. Beta or alpha? Beta. Mr. Beta, remember when I asked you, you have told me between up to 22. But this is for the CPAP patient, not normal patient. Huh? Normal patient less than 18. Tamam? This respiratory rate between 12 to 22. SpO2 saturation more than 92 with very low oxygen, FiO2 decreased. Hemodynamic is stable in the vital signs, blood pressure, pulse between 52 to 100, it's fine. pH more than 7.22, and this is the most important thing if you need to make weaning from the CPAP. Okay? Now, this is the, I think, what is the complication? Tell me, yeah, tell me. Which complication we have? Pressure injury. Others? Pressure injury, skin integrity is the same. Start skin integrity, after that, at the end, pressure injuries. In fact, they start skin integrity, after that, peel, peels, after that, blisters, after that, pressure injuries, like that. That peels look like start, if it's open, this is a problem, especially for the diabetic patient. Next, patient could be developing epistaxis, because pressure. Aspiration, also. Next, the patient could be, he has eye irritation, sinus pain. Complication, for example, with the patient with hemodynamic paratrauma, little, not so much, but could be happened. This is the mechanical ventilator, and this is the latest. Now, can you do extend orientation for the nurses that would go to ICU? This is important because we have a problem here and we have the intervention is here. Okay? For example, mass leak and with eye irritation, ensure the appropriate mask, including accurate size. The problem with all the time with the mask is size. Sometimes too huge, too big, sometimes very small, it's not fitting well, and this is the most important. And this is the medication we are talking at the beginning. The patient, summary, we are talking about the high flow oxygen, start with low flow. Low flow is divided for 3 parts, is a cannula, simple mask, not breathable. After that, high flow is what? High flow is a cannula, air O2 and CPAP. The last is you will go to what? The mechanical ventilator. How is the cost? Shows the issues now? Is it fine? Yes. Sure? Yes.
If you administer like 100% oxygen to a patient, does it mean if you open it above 15 liters?
Here.
From the low flow, we stop at 60 to 90.
Right.
The third one, yes. So if you give the patient 100% oxygen, does it mean it has to be above 15 liters for each patient?
Good. You remember when we reached level 3, we are going to the restoration here, to the next level. The next level is the high flow, okay? And high flow we have air O2. I'm not sure it's the same here in the field, but we remember we have temperature, we have flow rate up to 60 liter, but plus we are giving oxygen 100%. This is, but the issue is this is high flow, nasal cannula. Patient can't tolerate, we are going to the CPAP. Not tolerate, mechanical ventilator. Now, some of you, I don't know, I think they will distribute you to go to the clinical, but I will first go to the next level for the mechanical ventilator patient. The mechanical ventilator patient means what? Is the mechanical ventilator, is it a treatment or not? Is it a treatment or not? Yes or no? Yes, why? No, why? No. What does it mean? Yes, I agree. This is not a treatment actually. Just let's give oxygen and remove passively the CO2. This is important here. But as a nurse, this is very, very important to know. Number one, you need to know which mechanical ventilator you would like to work with. In the hospital here, we're working with McKay. And in the field hospital, there is General Electric, I think. Maria General Electric ولا ايش؟ Maria? Okay. I think General Electric. Whatever, it's the same. Now, we have important rule we would like when we make for the mechanical ventilator. The most important, the doctor will okay, this patient is not tolerate, go and prepare for intubation. You need to know how to prepare for the intubation. The best, right? Checklist for intubation for COVID patient. Or checklist intubation for COVID patient. Right. Go to the Google and search for that. If you need, sorry, almost. If you have access to our area, you can see, I will not mention here because there are too much things. 3 principles is important: pre-intubation management, and intro and post-intubation management. How to prepare the patient for intubation? Number 1, go to the RAS or RASI. This one, rapid sequence intubation. Rapid sequence intubation. Pina, take pictures. Pina? Yes, you. I see you. Pincy, take pictures. This is very, very important here. The first P is preparation. Second P, preoxygenation. Pre-medication. Paralyze induction. Positioning. Placement. Post-intubation tube. Now, for the preparation, it's the best to prepare checklist. All equipment you need, all medication you need, all crash card you need, this is very important. The best is to intubate the patient rapid, very fast, seconds. Not to take, no way, because the patient will be more and more irritation, and the patient will be maybe arrested. If the patient starts in that phase, he will not survive. You need excellent doctor to intubate. Other things, we are using here video laryngoscope, video, camera. We are not using that one. No, we're using the camera laryngoscope. And you need to be familiar with all these things is important. Number 1, ambu bag with what? With filter. Must the filter. You can't work in the hospital here without filter. We have 2 types of filter. We have the green one, the heavy filter, and the other one is viral filter. The viral one is the white one. The white one all the time we're using for the machine. The green one all the time with the patient. Tamam? Okay. Next here we have mask, we have airway, laryngoscope, medication, ET tube. This is ET tube with filter. Scope we are not using. Tie, close suctioning. Right, the medication is important. Right. Number 1. The medication for the reduction system is important. To paralyze. Number 1. Ketamine. Go and check the dose. Ketamine. Okay, ketamine. Number 2. Tracorium. Ismeron. Fentanyl. Remifentanil. Propofol. Brezidex. Sometimes they're using midazolam. You know the propofol? The white one, the milky one. Michael Jackson one. Okay? But the propofol you need, number 1, to prepare under strict sterile technique. Number 1. Should be changed the line every 6 to 12 hours. Bacteria loves lipid, the white one. lead to infection all the time. This is very, very important here. And that infection, it will come under something is called, what is it? See, I feel tired. ICU nurses. Read about that. Where's ICU? Read about this one. Bundle of care. In the ICU. Bundle of care. What is a bundle of care? Many interventions coming together to prevent a lot of complications. Which complications we have in the ICU? Number one, valve. Ventilated associated pneumonia. Number two, CLABSI. Central line associated bloodstream infection. Next, CAUTI. Catheter associated urinary tract. Others, SSI, surgical site infection. Others, شو كمان? We have more. You need to know what is the cause and what is the intervention and what is the hospital policy. Hospital policy is important. How, for example, to prevent the VAP, ventilated associated pneumonia. What is the difference here? The pneumonia could become the patient come with pneumonia from the beginning. Any patient came with pneumonia. The COVID starts with pneumonia. VAP, it's started after I intubate the patient 24 hours, 48 hours. 48 hours after intubation comes VAP. Okay? How to prevent? Number one, keep 45 degree. Number two, give proton pump inhibitors. Chlorhexidine mouthwash. Don't do suctioning as routine. Do the suction as needed. Okay? All these things, intervention is very, very important to prevent VAP. Come on? Labs, we have so many things you need to know. Let us to focus here first. This one also need to be very strict and to be very careful. Here, it's better to use which type of ET tube. ET tube here is what? مريم بدي شغلة أشرب ممكن يا أخت مريم عشان الاثنين بدي أشرب تشرب شغلة ممكن مريم You see? Okay. What is the best? The good nurse, for example, like Sister Karen, she will choose this type or other type? No. She will choose the type with subgluteal ET tube. Means what? Means we have catheter here for inflation, but we have another catheter for suctioning. Later I will show you. This is the best, huh? How many centimeters I will insert? Well, when did I see you? How many centimeters? 10? Yalla. 7. Very short. What? تضحك يا عماد. مبسوط على الشغل. 19 centimeters, 19 centimeters to 21. Bina, she knows, but she can't answer. I don't know why. She's scared. Up to 21. Huh? Why up to 21? We have one part here. It's called here the carina. That carina should be above the carina 3 centimeters. 3 centimeters. Why? To give oxygen for the right and the left equal. If we are go more little, it will go to the right, not to the left. Why? And make the left line collapse. According to that, the area is very important here. After that, when the doctor is inserting, the nurse, he will put 10 cc air inside the balloon. 10 cc. But how much pressure inside the balloon? 20 to 25 mmHg. Tamam? Is it fine? The instructions coming to me for the nurse, they will be in the ICU, give more information. According to that, I extend my lecture, to be honest. Okay? Because but I think this is important information for everyone, I believe. Now, why we are inflated the balloon? The balloon here, why we are inflated? Number one, to replace, for replacement. Number two, the most important, to prevent aspiration. Number three, to maintain enough tidal volume inside the lung. No leak. If we have leak, it will make aerosol, make a lot of problems for other patients. Okay, let us to go a little back. One by one. Preparation, the nurse will prepare everything. Checklist. Number two, preoxygenation. The anesthesiologist, he will make 3 to 5 minutes, 100% oxygen. Number four, pre-medication. They will start with muscle relaxant and paralyzed. After 45 seconds, he will start to intubate. After the patient خلاص, intubate and start to ammo bagging is not recommended for the COVID patient. Connected directly to the mechanical ventilator, closed system. Now, how to know the tube is in place or no? ETCO, Untitled CO2, correct, 35 to 45. Before we are using scope. Now we are not using for the COVID patient. And the doctor will be insert direct. We are clamp the tube direct. After that, put the dye. And other doctors, we have one doctor intubated, nurse, she will help. The other doctor, he will help in the medication or something else. The nurse actually for the medication. But we have a respiratory therapist here. They are preparing the patient for the mechanical ventilator exam. تمام؟ الله يسعد عينك. الله يا ريتها ما تبدو.
This means that one less.
Okay, let us just to go through. Step P1 is a preparation. We have a lot of preparation here. I will not mention everything. So many information here. Okay, preparation again. PPE is essential. Avoid pre-treatment with nebulization. Nebulization is not recommended because nebulization aerosol. Next, preoxygenation, 3 to 5 minutes by doctor. Next, doctors, you will start with norepinephrine, epinephrine, give fluid. It depends on the patient condition. Ismeron, we are given 1.5 milligram per kg IV. Saxocycline, we are given 2 milligram. The goal is the rapid onset without coughing. Eliminate cough. It's important here. The protection refer to the post-intubation. Placement the tube by ETCO2. This is the ETCO2. Inhalation, it will go down. Inhalation. Exhalation phase, CO2s go up. We are checking the ETCO2. Tamam. Post-intubation, inflate the cuff, confirm the placement of the tube, and make the why I mentioned all when I see you. Because to be sure for documentation. What happened all the time? We are inserting it 1 to 1. When I receive the patient during the night, it's 17. The tube is going where? Up. Bye-bye. This patient will be making problems, and this patient could be developing aspiration or semi-extubation. The problem with the COVID patient is not easy to re-intubate again. Because of what? The mucosa will be becoming large. Difficult to, with sometimes stiff trachea. Next, ventilate sitting suitable with the patient with ARDS. All the time think about ARDS. Sorry يا جماعة. هلا مرة. كيفك شو أخبارك؟ تمام، بس معلش.